I wear several hats. The first hat that I wore, actually, no, technically together, I got my PT hat and my cancer survivor hat at the same time because I was diagnosed in PT school. So I'm going to do my best to talk about how do we move and how do we exercise after a cancer treatment. And just as Maura was talking about, food is medicine, exercise and movement is also medicine. But first I'm going to tell you what is a physical therapist. And if you go by my governing body, the American Physical Therapy Association, supposedly we're experts in movement and function, and we are trying to promote health and wellness for all Americans and preventing functional decline in the development of certain conditions. And I will preface that by saying within our national government body, the APTA, we are actually just now coming on board and realizing that in addition to orthopedics and pediatrics and neurology and geriatrics, we are finally coming up with a specialization certification for oncology specialists. So what can we as physical therapists do for cancer survivors? Well, we can screen for decreases in range of motion. Anybody who's had surgery and especially radiation to a surgical site, you may have limitations in your range of motion, your ability to move your limbs, and so we can screen for that. We can screen for a decrease in strength, which can be caused by surgery, chemotherapy, and radiation therapy. We can screen for decreases in balance. We heard a lot this morning from our amazing speakers about peripheral neuropathy. I'm going to get more into that in a little bit. And if you can't feel your feet because of peripheral neuropathy, you're at risk for falls. Decreased energy, again, this idea of cancer-related fatigue, which I'm going to get to in a minute, again, can be caused by the combination, the cumulative effects of surgery, chemo, and radiation. Scar tissue management, again from surgery. For those who have had lymph nodes removed, this was talked a little bit about this morning with the condition called lymphedema. There are a specialization to be specialists in lymphedema management. This can actually be a physical therapist or an occupational therapist. It's a pretty intense 3-week training. So anybody that makes it through this process and this certification exam, they'll have the letters CLT after their name, so you know that they are certified in lymphedema. And then, as I was just alluding to a moment ago, the first class of specialists in oncology rehab from the American Physical Therapy Association will be announced later this month. So when is it appropriate to see a physical therapist? And again, as Maura was talking about, you really need to think about your nutritional health before you even start surgery for cancer, during cancer treatments, and after cancer treatments. Rehab in physical therapy and exercise is no different. So in rehab, we actually call it prehab. If we're going to try to do some strengthening and exercising prior to surgery. So for some cancers, you might be doing 4 to 6 weeks of neoadjuvant chemotherapy, and that's actually not a great time to talk with the patient about how do I get you stronger, how do I get you ready for surgery? And really, it's not reinventing the wheel. If I was going to have my ACL replaced, I would go to the orthopedic, and he would say, well, I want you to do rehab for 4 weeks before you go into surgery, because I want you to be as strong as you possibly can be going into that surgery. During active treatment, we want our survivors to try to move during chemo and radiation. And Jay and Maura, I apologize because you've heard this story many times over, but I feel that I need to tell this quick 30-second snippet of my own history. As I was about to start my chemotherapy, I was looking at bleomycin, cisplatin, and etoposide after I'd already gone through 2 surgeries. And my oncologist sat me down and he said, you're going to lose your hair and you will be nauseous and your immune system will take a hit. And he went through the whole laundry list of side effects that I'm about to face. And he said, do you have any questions? And I said, yeah, can I still run while I'm on chemo? This was 1999. exercise was contraindicated in 1999 while you were going through treatment. So we've come pretty far since then. And then as far as survivorship care is concerned, both in what we consider short-term survivorship, less than 5 years, and long-term survivorship, which is more than 5 years. Being able to keep tabs on our survivors who've had lymph nodes removed, being able to screen for lymphedema, being able to screen for radiation fibrosis syndrome. That's something that doesn't necessarily show up until 3 to 5 years after you've finished radiation therapy. And in our breast cancer population, something called axillary web syndrome, or some of you may know it as cording, where you actually develop sclerotic tissue right through the armpit. That can show up after you've actually finished your radiation therapy. So we need to keep tabs on these conditions as you're moving through long-term survivorship. And then also in palliative care, there's also a role for physical therapy for cancer survivors as far as pain management, safety at home, again, making sure that the home environment is safe for not just the cancer patient, but the caregivers as well. So before I get into how do we exercise as cancer survivors, I'm going to talk about some of the barriers that some of us as cancer survivors run into, which makes it harder to exercise. And the most common one that all cancer survivors run into is cancer-related fatigue. And the NCCN defines it as this distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion. And I think that we need to make sure that we distinguish this here. This is not, the fatigue that you feel after you've been out until 3 in the morning, that kind of a thing, or the fact that, maybe we have a young baby at home and so you've been up several times, that sort of thing. That's a different type of fatigue. You can rest as much as you want and the fatigue does not go away. We know that this is caused by the body being insulted by surgery, chemo, and radiation. Again, this is probably the most prevalent physical effect that patients will report. It can be as high as 70 to 80%. And again, this is more severe, more distressing, and is less likely to be affected by or relieved by rest. So again, what causes cancer-related fatigue? Again, chemo, radiation, surgery, stem cell transplants. We had an amazing talk about that this morning. Just the cancer process itself, I failed to put in here, probably the stress, the emotional stress of cancer as well could contribute to cancer-related fatigue. And then if you have any other pre-existing conditions like high blood pressure or something like that. And so how is this going to affect you as a cancer patient and a cancer survivor moving forward? Well, it's going to decrease your physical function, your ability to actually move, being able to go to work, your mood, your self-worth, your ability to interact, have social interactions with other people, and then can also have changes to your cognitive performance as well. So when I'm in clinic and I'm talking with people and they say, I feel tired all the time and I don't know how to get out of this. People are stuck in this cycle, right? They're stuck in this fatigue cycle. And so the goal of rehab and the goal of exercise specialists when it comes to cancer rehab is how do we break that fatigue cycle and how do we create a new cycle of exercise? And it doesn't happen overnight, and I'm going to get to that in a little bit. But that's truly, at the end of the day, that's what we're trying to do. We're trying to break one cycle so that we can create a new cycle. We can replace it with a new one. So research has shown that aerobic endurance training in combination with moderate strength training can help reduce fatigue. So anywhere from 3 to 5 hours of moderate exercise a week, which I know sounds like a big number. So again, I'm going to get into the real nitty-gritty of how we're going to do that in a little bit. But again, if we're thinking about movement as medicine, this is the best way to fight this cancer-related fatigue. We heard from several of our amazing speakers this morning about peripheral neuropathy. And so if you've experienced chemo-induced peripheral neuropathy, you know exactly what I'm talking about. The burning, the numbness, the tingling in your hands and your feet. And we're pretty confident that we can point to specific chemotherapy drugs that will cause peripheral neuropathy. We know that the taxane family, the Taxol and the Taxotere, that those are a big enemy when it causes peripheral neuropathy. We know that some of the platinum-based chemotherapies, like cisplatin and carboplatin, can also cause peripheral neuropathy. And then we see this more in the pediatric population, the vincristines and the vinblastines, or the Ewing sarcomas. Those can also cause chemotherapy. So we know we can pretty much nail down, it's not every single chemotherapy is going to cause peripheral neuropathy, but we're pretty sure that these three particular families are going to cause peripheral neuropathy. And again, it's important to point out that chemo-induced peripheral neuropathy is different than diabetic neuropathy. Diabetic neuropathy is more of a circulation issue. This is more of a nerve issue. So again, it affects what we in our profession we call it like the stocking and glove distribution, right? It affects your hands and it can affect your feet. And so as we were talking about before, if you can't feel your hands, you can't get dressed. I wouldn't be able to do my tie in the morning. I wouldn't be able to hold a glass. And if it's affecting your feet, if you don't know where your feet are, how are you going to know where you are coming up these steps? So it becomes a balance issue. So while somebody is currently getting chemotherapy, if they start to experience peripheral neuropathy, the oncologist may alter the dose. They may try to lessen the dose, but that can have significant implications, right? If that person is not getting the full dose that they're supposed to be getting of chemotherapy, what's going to be their outcome medically? So we need to be really cognizant of that. How do we measure peripheral neuropathy? So there's a bunch of different assessments that we as physical therapists and occupational therapists can do. We do have some subjective questionnaires and some 2-point discrimination tests that we can do. I like to point this one out because for those of us that have been speaking, we work at these multi-billion-dollar cancer institutes around the country. But actually one of the most effective ways to measure peripheral neuropathy is a tuning fork. You take a tuning fork and you strike it, and you can put it on your ankle or you can put it on your wrist, and there's actually timed norms as to how long you can feel that vibration. And if you can't feel the vibration after a certain amount or in a shortened amount of time, we can actually pinpoint and say, okay, yes, we can objectively measure that you have peripheral neuropathy. I always get a kick out of, like I said, we work for these big, huge institutions, and something as simple as a tuning fork can make that diagnosis for us. So here's a big question. How do we actually treat it? Again, I told you that chemo-induced peripheral neuropathy is different than diabetic neuropathy, so we have to go at it from a different perspective. And I'm going to give the occupational therapists all the credit in the world for this concept, this idea of desensitization. We're going to try to desensitize those nerves, because that's essentially at the end of the day, that's pretty much what we're talking about. The nerve endings, the sensory nerve endings in our hands and our feet are fried from the chemotherapy. So how do we get them to come back online? Is through this idea of desensitization. So what I'll tell patients to do is, again, we're going really high tech here. Look around your house for different kinds of textures, like a shower loofah or like a piece of felt or a piece of corduroy or something like that. Obviously nothing sharp or abrasive. And what I want you to do is I want you to take that loofah and massage your hand, right? Top, bottom, get in between, do all of that. And then I want you to take the felt and do the exact same thing. And then you're going to take the corduroy and do the exact same thing. And the idea is that if you're introducing different textures, to your hands and to your feet, you're forcing those nerve endings to wake back up. And I've also had, again, as Maura was saying, like we listen to our patients so often. I've had so many patients say that Epsom salt, soaking their hands or soaking their feet in Epsom salt can provide relief for peripheral neuropathy as well. One of the big things that we also recommend is cardiovascular exercise. And in this instance, for most people, I'm going to say I want you to do weight-bearing exercises, but for somebody who's got peripheral neuropathy in their feet and they can't feel where their feet are, I'm not necessarily going to put them on a treadmill because that's a safety issue. So I may say start off on a bike instead to try to get things going. Hand strengthening exercises. So if you were to come into a physical therapy clinic, they were going to give you these color-coded, basically silly putties that are all graded in resistance, and you can pull it apart. And by doing that, you're strengthening the fingers, and you're also giving those fingertips the input that they so crave at that point. If you have little kids or if you have grandkids, I always tell people that they can put like beads or coins in there, and so it becomes a game that you got to like pull it apart and find all the beads or find all the coins that are in there. So for foot strengthening exercises, I'll have people put a towel down on the floor, and I want them to scrunch up the towel with their toes because we're getting those intrinsic muscles of the foot and the toes to really get working. And again, you get that sensory input from the towel. And then I'll also have people do balance activities because, again, I want them to practice relearning what it feels like to stand on one foot and to do like a tandem stance and that sort of thing. There's some evidence of low-level light therapy for peripheral neuropathy, and then I didn't list it here, but there's actually emerging research that acupuncture can help with peripheral neuropathy as well. And so I listed in here, this is kind of my take-home exercise program that I will give for people when it comes to peripheral neuropathy. Again, some of the strategy that I just talked about, some of the hand strengthening exercises. The one on the bottom there, my bottom left, the one with the dice I like as well, in addition to those strengthening exercises with the silly putty or the TheraPutty. So you can open up a game that you have at home and just take the dice and just kind of roll the dice around in your hand. Seems pretty simple, right? If that feels simple to you, close your eyes and then do it. Because if you take your vision out of it, you're truly relying on your sense of touch to figure out where the dice are and to keep the dice in your hand. And again, some of the exercises that I just described for your feet and for the balance exercises. Now, specific to breast cancer, one of the big things that we also see in our clinic are women who are experiencing arthralgias or the joint pain from the aromatase inhibitors. So just briefly, the AIs are given to women whose breast cancer is estrogen and or progesterone positive. The great thing is that use of these medications can reduce the risk of breast cancer recurrence by 50%. Right now, we're telling our breast cancer survivors to stay on this for 5 years. There's been some debate whether we should be on for 10 years, so that's kind of back and forth. And you'll know them commonly by the names of Femara, Arimidex, and Aromacin. So actually, the two really big side effects that I'm concerned about as a physical therapist, as far as physical issues that these side effects or these medications can cause, is the joint pain, the arthralgias. Primarily the knees, hips, and fingers, especially the thumb joint. It's worse in the morning. Again, it's affecting your activities of daily living. That's what ADL stands for, such as getting dressed or holding a glass. It also decreases your mobility, because if your hips hurt and your knees hurt, you're not going to feel like moving. I wish I had $1 for every time a woman said, I feel like I've instantly aged 20 years by taking this medication. The other big physical side effect, which I don't think gets enough press, is that these medications, again, while they are very effective at reducing the recurrence of breast cancer, they accelerate bone loss. You naturally lose 1 to 2% of your bone density anyway, just in the natural aging process, but women who are on these aromatase inhibitors, it accelerates that. So all of a sudden, you have women who are gonna get thrown into osteopenia or osteoporosis faster. And if somebody already has pre-existing osteopenia, it's gonna throw them into osteoporosis much faster. So again, how are we gonna try to treat this? Again, by movement, by increasing cardiovascular exercise. And for this population, absolutely, I want weight-bearing exercises. I want walking, jogging, hiking, yoga, anything that's gonna produce any kind of weight-bearing activity through the legs and through the arms. And again, and strength training as well. Because strength training is going to target those large muscle groups, right? It's going to target our shoulders, our lats. It's going to target our quads, our hamstrings, our glutes. And on a real simple physiological level, when you do strength training, it's like safe strength training, you actually are creating little micro tears of the muscle from the bone. But that's what's actually stimulating bone growth. That's the effect that we're going for. Now, I put this last bullet point up because, again, I think I learn more from my patients than I do from research articles. I've had more than one woman come back to me and say, I went on Amazon and I got one of those Paraffin Baths, and I will just stick my hand in there, and get the wax and wrap my hand for a couple minutes in the morning, and my hands feel great afterwards. And they're right. Because if you came to a physical therapy clinic, what's the first thing that we're going to treat you with? Heat. So, but you can do that at home. So I think it's $79.99 on Amazon. Obviously you got to keep paying for the wax and everything. But that's the other thing too. Like the aromatase inhibitor arthralgias, you treat it like classic arthritis. It comes from a different source, right? It's not regular arthritis. We know that I call it chemically induced arthritis, but we're going to treat it like classic arthritis. So the question is, if you're experiencing peripheral neuropathy, if you're experiencing these AI arthralgias, if your range of motion is not what you think it is, or you still feel tightness across your surgical site, how are you going to get this referral to outpatient rehab? Well, you can ask your medical oncologist, your surgeon, your radiation oncologist. We get a lot of referrals actually from our APPs, our APRNs and our PAs. Our social workers sometimes will make those referrals. Our primary care physicians will make those referrals. But sometimes we'll have the patient do a referral too. There are some states, I apologize that I don't know off the top of my head if Massachusetts is or not, but there are some patients that you can actually, it's called direct access, and the patient can actually go to PT without a physician's signature. So this is the one slide that I'm going to try to spend the most amount of time on, is after I've told you why we should exercise and some of the barriers to exercise and how to get around that, how do we actually exercise? How are we actually going to move? Well, one strategy is to write it down and track it. And in 2019, a lot of people have the Fitbits and the Apple Watches and that sort of thing, which is great. So it's pretty much right there on your wrist, and you link it to your phone, and you're able to track the number of steps that you do over the day. You can track your heart rate, you can track your sleep, and that's great. But for some of us who are technically challenged, you can go old school and just write it down. How much exercise did you do today? I went for a 15-minute walk around the block. I went for a 20-minute walk through the park. Or I went to Mount Monadnock and I did a 2-hour hike. You can write it down. And again, to try to build up to the recommended amount of cardiovascular exercise, which is 150 minutes a week of exercise, that doesn't happen overnight, right? We're not expecting that to start tomorrow. It's a gradual build-up process, which is why tracking it is so important. To say to yourself, on June 8th, I went for a 10-minute walk, or I went for a 15-minute walk. And then keep tracking it and keep slowly progressing the length of those walks before you increase the number of walks that you do, so that by the time you get to July 4th, you say, oh, well, now I'm doing a couple of 20-minute walks or 25-minute walks. And by the time you get to Labor Day, you say, oh, now I'm doing a couple of 30-minute walks, and I get to do one long walk with my friend on the weekends. So you can actually look back and see the progress that you've made. So which ties in next to the next point. Exercise with a friend or a coworker. I guarantee you, if you call up or you text a friend and say, okay, let's go meet at the park, or where Maura and I live, we live down by the shore in Long Island Sound. Let's go meet at the beach or whatever at 8 a.m. on Saturday. You better be there, because if you're not there by 8:10, you're getting an angry text. I'm here. Where are you? So if you need to put the onus on somebody else to hold you accountable, that's fine. That totally works. So another thing that I tell people about is setting specific goals. And again, start off small. It can be as simple as, I want to be able to walk around the block one time. And once you accomplish that, okay, now my next goal is to do twice around the block. A lot of the 5Ks that are out there now, they have all have walks attached to them. And I love this, and I'm gonna pick on Maura. Again, we've known each other for a very, very long time, so I'm gonna just pick on you for a second. I love this idea of an active vacation, right? I remember a couple years ago, Maura went to the Grand Canyon, and she asked me, she said, I'm gonna hike down into the canyon, and I'm gonna stay there for a couple nights, and I'm gonna hike up, but I gotta carry all my gear with me. So how do I physically get ready to do that? And I said, well, it's not just good enough to go for a hike on the weekend. You've got to hike with 10, 15 pounds of gear on your back so that your body acclimates to the demand that you're going to put on it when you go for this hike. So that's what she did. She would go for long hikes. She'd wear her gear, or she'd walk multiple flights of stairs to kind of get ready for all of that. And she had a great trip, and she felt great because she was prepared. And she had, in a vacation of a lifetime at the Grand Canyon. So I'll tell people to do that. I say, listen, after everything that you've been through, you owe yourself something. You owe yourself something nice to go on a nice vacation. You can have some fun with it at the same time. And then planning ahead. I've got small kids at home, so my time is not my own. My time belongs to them. So I have to get really creative when it comes to exercising. I remember when they were little, like when they were infants and they would nap, I'd put the baby monitor on in their room, and then I would, as soon as they were asleep, I'd run downstairs and I'd get on the bike, and I had the other baby monitor right in front of me, and I would ride my bike while they were napping. And then if they started to wake up, I'd say, okay, my ride's done, and then I got to go back upstairs. But so I was creating time in my day to figure out when I could exercise. I've even gone for a run when I dropped the car off to get the oil changed, because I got 30 minutes. I can do something in 30 minutes. That's my time. The kids aren't there, so I can do something in that time. So again, take-home message. Cancer survivors can and should exercise. So the idea of cardiovascular exercise mixed in with a little bit of strength training should be part of your exercise routine. And again, just as Maura was talking about, food is medicine, movement is medicine. And again, as I was just talking about, like planning ahead for the day, like looking at your schedule for the week and trying to figure out when you can plug it in to your schedule. You ask yourself, did I get my exercise in today? Or how am I going to get my exercise in tomorrow? Where am I going to find that time in my day so that I can stay healthy and be the best cancer survivor that I can be? Thank you for the privilege of the podium. Any questions? The question was, does peripheral neuropathy ever go away? And I don't mean this to sound like a cop-out, but it's very variable depending on the person. Typically, in the research, we've seen that peripheral neuropathy can last up to 2 years, sometimes longer. So that's why the rehab interventions will try to help. And if it doesn't take it away 100%, it hopefully lessen the impact. And that's why we have those assessments to try to figure out, is it getting better at all?
If it doesn't get really better 100%, can it cause you any harm in the future years when you get older? You know?
The question was, can the peripheral neuropathy harm you as you get older? Again, I think everybody is very variable. So I can tell you, again, switching hats and putting my survivor hat back on, my neuropathy is more of like a temperature sensation. My hands get cold really quickly, and it's gotten worse with age. So I've had to learn to be very creative. If I go for a run in the wintertime, I have no modesty left anymore, so I will wear my big, thick LL Bean mittens, and I will stick hand warmers in there so that my hands don't go into shock. So it's possible. I apologize that I don't have a better answer for you. Yeah, that cold sensitivity is a variation of the peripheral neuropathy. Yeah. Yep. Yes. That's correct. Yes, absolutely. The question was about doing range of motion exercises to prevent radiation fibrosis syndrome and cording. And you're spot on, absolutely. That's why we want our survivors to move as early as possible. We need to have our survivors doing their range of motion exercises before they even start radiation therapy and getting into that routine of doing their exercises and their stretches so that it lessens the effect of that radiation fibrosis syndrome. And cording, specifically for cording, again, it looks, for anybody who's had it, you know what I'm talking about. It essentially looks like a guitar string in the armpit. And a physical therapist or an occupational therapist can do a specific manual technique. Literally, it pops. And all of a sudden, your range of motion goes from here to here.
I feel like I had that, and then it went away.
Okay.
So it could have been that
Just by being in active movement and moving your arm around, you probably loosened it up. Any other questions? All right, well, thank you very much. Jay, thank you very much for having us back.